Dear colleagues and friends, it gives me great pleasure to invite you to the launch of the first tranche of papers in the BMJ series on women's health and gender inequalities. The series, commissioned by the BMJ with support from UN University Institute of Global Health and WHO, to mark the 25th anniversary of the Beijing Platform for Action on Women. The Beijing Platform for Action was a landmark declaration, and one that 25 years later remains very much relevant and urgent today, despite the successes and progress in women's health and gender equality that we must celebrate. Health was one of the 12 areas in the Beijing Platform, and all at that time, and coming out of the successes of the ICPD, the focus was very much on HIV and sexual and reproductive health and maternal health. Although women's health was recognized as needing attention to issues of mental health, NCDs, WHO has continued to contribute to this 25 years ago with a position paper that outlined 10 priorities for women's health. For this series, we have a joint opinion piece by the WHO Director General, the UN Women's Executive Director, and Director of UNU that calls for investing in women's health as a moral imperative as well as smart economics. It also calls for women's leadership in health, policy making, and for male leaders to adopt feminist health policies. Thank you to our panel participants, to the authors, to the BMJ, to all the participants in this session, and to those working tirelessly around the world towards a brighter future for women's health and gender equality.
Good morning, good afternoon, good evening to everyone. My name is Pascal Alote. I'm the director with the United Nations University International Institute for Global Health. I'd like to welcome all of you to listen to the panelists today, who will share some of the reflections about this series and key messages from some of the papers that are online today. Please keep your mics on mute. Engage actively by posting your questions and comments in the chat box, and we will select a few questions that our panelists can respond to. The panelists include me, Pascal Alote, Dr. Asha George, who is the lead author for a paper on violence faced by women health workers, and is based at the University of Western Cape. Dr. Lavanya Vijayasingam, who is the lead author of the paper on employment-based health financing implications for women. And Lavanya works with me at the United Nations University International Institute for Global Health, and she's a postdoc fellow based with us in Kuala Lumpur. Dr. Claudia Garcia Moreno, who is the unit head of the section addressing vulnerable populations in the Department of Sexual and Reproductive Health and Research, and is the lead author of the paper reviewing the unfinished agenda of the Beijing Health Chapter, including on sexual and reproductive health. Dr. Paul Simon kept us on the straight and narrow, and he is the series editor at the BMJ and the lead for commissioning the series, and who will provide the closing remarks and the next steps for completing the series. Each panelist has 3 to 4 minutes maximum. And if you're not sick of me yet, I will start up with my presentation. Very brief comments to start. Asha, Lavanya, and Claudia, please tell us 3 key messages in the papers you have co-authored in this series including the implications for women's health in the future. And we will just keep it going because we don't have much time and we absolutely have to stay on time. So very briefly, just to open up the panel, within the United Nations engine, the promotion of equality for women is almost as old as the UN itself, with the establishment of the Commission on the Status of Women in 1946, 74 years ago. Almost 30 years after that, in 1975, the UN held the first International Conference on Women to focus on persistent problems of oppression, inequality, and inequity. 1975 was the International Women's Year, extended to a decade for women to set a target for evaluation of progress on the elimination of discrimination against women. Fast forward 20 years to 1995, to the Fourth World Conference on Women and the 50th anniversary of the United Nations. And this time things got really serious. We got the Beijing Declaration and Platform of Action. Now, this was a landmark for many reasons. It was a big UN meeting with representatives of 189 governments. And regardless about how many perceive the UN as a giant bureaucracy, the reality is that the UN is all of us. It wouldn't exist otherwise. But the Beijing meeting also, in 1995, attracted 17,000 participants from all over the world, 30,000 activists, all with all the diversity that these numbers represented. And there was one message: gender equality and empowerment of women. And the outcome gave us something concrete to work with, a progressive blueprint for advancing women's rights. In health, it guided a direction to focus on issues that affected women: sexual and reproductive health, violence against women, occupational exposures and risks. But it was not just women's health, as in read biological or clinical. It provided a pioneering ways forward, led by the technical units at the World Health Organization, to push for sex disaggregated data to begin to explore the gendered nature of health, highlighting the needs to address power imbalances and to interrogate the very nature of institutions in their ability to recognize that as a matter of social justice, equity, and human rights, there remain deep-seated inequalities that impact on women's health. So here we are after 25 years. Has there been progress? Undeniably. But if the changes we sought had materialized, we wouldn't have seen the regression that has been evident in gender equality over the last few months of the COVID pandemic. And the intersectionality with race, ethnicity, geography, indigeneity, age, class, caste, and poverty has been devastating, and further compounded by a toxic geopolitical environment, a planet that is unable to sustain us, and in many places, leadership that denies that we have anything to worry about. So there is still absolutely a women's agenda that is unfinished. And I'm absolutely thrilled to have been a part of this exciting collaboration with WHO and the BMJ, and a group of wonderful authors from every continent to review achievements across a range of priority health areas and open up a revised health agenda that takes into account the new opportunities offered in 2020 by technologies, partnerships, and innovations, as well as recognize the new obstacles presented in today's realities. I invite you to visit the relevant pages through the websites of the BMJ, WHO, and UNU-IIGH. Thank you very much. And now I will open it up to the next speaker. That is, I believe, Lavanya.
Thank you, Pascal. It is a privilege to talk about this paper today. I'd like to take this opportunity to shine a spotlight on my co-authors, Dr. Viloshni Govenda, Professor Sophie Witter, Dr. Michelle Reme, to acknowledge their expert insights and contributions. So I want to start by saying that healthcare is a human right. It should not be an employment benefit. But for so many around the world, the terms of their healthcare access is tied to their employment status, types, and linked ability to pay. The thing is, employment-based systems can be unstable and inequitable, especially during a crisis. So as of May this year, about 47.5 million in the US lost employment-linked healthcare, and 27 million of them were ineligible for an alternate scheme. They will likely remain uninsured unless there's a change in their circumstance. Women's employment is particularly affected during these times, adding to the existing employment inequalities they already face. Women are overrepresented in full-time unpaid care work. Women in the formal sector are overrepresented in lower positions. Women are more prone to non-standard work, such as part-time, temporary, and gig-based work, where they face higher income gaps and employment insecurities with lesser employment protections, including linked mandatory health schemes. Women in Asia and Africa are overrepresented in the informal sector, again, with lower pay, less regular income, often no social protection, and where enrollment for linked health schemes are often voluntary. So the central thesis of this paper is health financing and entitlement systems that are linked to employment can further disadvantage women's continued healthcare access because the design of such schemes often do not take into account women's unequal and disrupted participation in employment. Allow me to highlight some key points. First, there's often variation in the levels of benefits offered and the extent of financial protection delivered through the different parallel schemes that cover different populations of women. So women as dependents, women as non-standard workers, they tend to receive healthcare access through public or mandatory systems on different terms than women who work in full-time paid work. So this is the case in South Korea, where there are different schemes for formal, full-time, and non-standard workers. Similarly, in Vietnam and Thailand, there are differences for the dependents' access between various schemes. So my second point, as is highlighted during this pandemic, such schemes can also create conditions of discontinuous access to high-quality healthcare when there are changes to work status. Women have more fragmented careers over their life course due to reproduction, care work, voluntary and involuntary unemployment. So in Mexico, for example, there are differences in formal and informal sector health schemes. Employment changes, which women are more prone to, is shown to result in changing access to quality healthcare that then also negatively affects health outcomes. So yes, we argue employment-based schemes are a problem for gender equity in UHC. So what are the solutions we propose? First, health entitlements must be delinked from direct payment, and parallel schemes should aim to equitably deliver benefits, quality, and financial protection to everyone. Changes to employment status, type, income, or life roles should not impair an individual's access to adequate, high quality, and timely healthcare. The second, and the key action call from this paper is UHC design and policy reforms must include the pursuit of gender equity. Gender-biased design, such as different benefits packages across the schemes and gender-based insurance pricing, should be avoided. Unpaid care, informal and non-standard work should be more equally valued in coverage, financial protection, and benefit design. So please read our paper for more details. Thank you.
Let me hand over to Asha to just take us through your presentation, please. Thank you.
Thank you. Thank you so much. And I'm going to share, I'm very honored to have this opportunity to share the paper that I wrote with colleagues at WHO, at other universities, managers of health departments, and policymakers. So I had the privilege of working with Francis McConville, Rahim DeVries, Gustavo Nihenda, Shabnam Safras, and Michelle McIsaac. And I'm projecting the slide. I hope you can see. We really had a lot of fun working on this paper, and we visualized the key issues around this image, which encapsulates the way we think about this issue. So the Beijing conference recognized women as key providers of health, not just users of healthcare. 25 years later, the predominantly female profile of the health workforce is now finally recognized. However, the potential contribution of women health workers to advancing global health remains inhibited by several factors. One of the most extreme and harmful of these factors is the violence perpetrated against women health workers. Such violence we've seen continues even as they respond to the COVID-19 pandemic. It's crucial to recognize, we argue, that such violence, responses to such violence must go beyond mitigating individual cases and understand that it's enabled by systemic gender inequalities. And that's what we try to map in this paper. These gender inequalities mark the health workforce, and we outline them by asking 5 questions. So firstly, what is known about the problem? There's ongoing invisibility of the issue, as established surveys are not routinely implemented as part of health facility surveys, and there's stigmatization of survivors that undermine reporting of the problem. And this leads to the misperception that it's not a problem that we need to address, or it's a minor problem. 2, who has what? Even if there's apart from the lack of evidence and data collected in a systemized way, there's a lack of trusted independent reporting mechanisms within the health workforce, the health workplace, that enable women to have the trust to come forward. And even if those mechanisms exist, many of them lack teeth. It's striking that in 2019, 59 countries did not have laws prohibiting sexual harassment in the workplace. Moreover, 100 countries have no civil remedies for sexual harassment in the workplace. And it's even more if women try and press criminal charges. Who does what? What's striking is that even though the health workforce, there's so many women in the health workforce, there's pervasive issues of low pay and unequal pay. In fact, the gender pay gap in the health sector is larger than the average of all other labor sectors combined. And we know that on the front lines of the COVID-19 response, a lot of community health workers and carers at home are not even paid at all. These are part of the systemic inequalities that make it hard for women to come forward. Finally, 4, what is valued? There's a systemic problem of the lack of professional recognition of female-dominated cadres. They're often lower down the hierarchy and have very restricted autonomy due to a systematic devaluing of their skills and contribution. And finally, as has been highlighted a lot in the last 2 years in global health, who decides? There's a lack of opportunity for women to lead and preparedness to do so. Even in leadership, they're often not supported to lead in a male-dominated medical hierarchy that continues to shape global health. So our paper argues that these inequalities, it's absolutely critical to name them. They have been normalized far too long and accepted for far too long. And we need to understand that they're sustained by gendered ideologies and biases rooted in gender power relations. Unless we address this comprehensively and systemically, we'll continue to undermine the potential of women health workers who represent the bulk of our frontline response to health emergencies, including the global pandemic. Thank you.
All right, Claudia.
Shall I jump in? Okay, I'll jump in straight to the 3 key messages in the paper. The first one has already been named by Pascal. We have made a lot of progress in the 25 years since Beijing, but this progress has been uneven and pockets of inequality remain. If we look, for example, at maternal mortality, it has gone down globally, but it still remains a major killer of young women and of women in Africa. And this is mostly preventable. Another example is cervical cancer. We have made great progress in visual screening, and we have HPV vaccine that we didn't have 25 years ago, but still not sufficient funds to support screening programs, and mortality remains high, particularly in many low and middle income countries. Mortality from HIV has gone down. We have treatments that we didn't have 25 years ago, but new infections continue to be highest among young women. So all of these are areas in which we've made great progress, but we need to do more and particularly focus on the specific groups that are most affected. And last but not least, as we are all aware, reproductive rights, which was one of the big, I would say, victories of the ICPD and the Beijing conferences, remain contentious, and the backlash is alive and well. The second message is about the epidemiological shift towards non-communicable diseases as causes of death and of years lived with disability, even among young women, and the importance of mental health as one of the leading factors affecting the lives of women, closely related to gender inequality and the other multiple forms of discrimination that groups of women face. We also see a growing rates of suicide among young women. We have the largest cohort of adolescent women at present, and we also have a very growing numbers of older women who are living longer, but not necessarily healthier lives. And both these groups need attention. In terms of adolescent girls, we still see high rates of early marriage and child marriage, and we see challenges in terms of access to contraception, to safe abortion, and to other services which contribute to unwanted pregnancies and early pregnancies and school dropout, which has lasting impacts on the lives of women and girls. The third message is around determinants. Much of women's ill health, particularly those causes that are preventable, are closely and still driven by the persistent gender inequality, which Asha has just eloquently referred to. It's not just at the individual and the family level, but it's also structural. And we are much more aware now of how this gender inequality intersects with other factors and other layers of discrimination, be it on the basis of race, ethnicity, disability, gender identity, migration status, etc. And these are areas where we need more attention. We have at the same time also new opportunities. Pascal already referred to technologies, innovations, and partnerships. We have seen a growth of grassroots movement to bring attention to inequalities and to demand change. We have see, for example, the Black Lives Matter in the US, Me Too, youth movements around consent and reproductive justice, movements to protect the rights of people of different gender identities. And all of these are opportunities for the global public health system to develop new partnerships. We see also in global health shifts to and a greater recognition of the importance of colonization and other political and historical determinants in how they impact on health, particularly in LMICs. And we also see a growth in a shift towards involving, for example, young people or people with lived experiences of different health problems in developing and implementing policies. So we need to build on these new partnerships. We need to support movement building. And lastly, we are all have COVID-19 as an ever-present feature in our lives, and we need to also see it as an opportunity and ensure that rather than let it take us backwards, we build on the innovation that it has led to, the addressing the structural and other inequalities that it has pointed to and really highlighted, and ensure that we increase the access to quality, gender appropriate, and non-discriminatory services for all women globally. Thank you.
Thank you very much for that, Claudia. We shall immediately go straight to you, Paul, to give us your insights. Thank you very much.
Well, thank you very much. So the first thing to say is that the BMJ are really excited to be publishing this first wave of papers in our gender series. And you can read all the papers for free. They're all open access, and you could probably read them on the WHO website and the UN website and the BMJ website. And I would encourage you to go to bmj.com/gender. I would also like to thank Pascal, Rachel, Michelle and Avni for keeping me on track as we've worked through the first series of papers. And I think that, you know, every time as an editor you kind of work on a new project like this, it's really an education, because I'm not an expert in any way, shape or form in gender. And one of the kind of you know, really powerful things that I've learned is to think about gender through the lens of power, and that's through this kind of work that Asha has been doing. And I think the two papers that we've published alongside Asha's paper really show how decision-making power can have a big influence on sort of gendered healthcare, even if those decisions are quite a long way from actually delivering healthcare. So whether that's how we finance healthcare, or how we the research questions that we ask, and how we regulate the sort of development of drugs. And I think thinking through that lens of power has given me the opportunity to think about the power that I have and that journals have in you know, in our role in this kind of global health space. And I think it's important to think about who it is that's on our editorial boards, you know, the power that we're giving to sort of make decisions. Who is it that we're asking to write? Who is it that we're asking to review? And who is it that we're working with? And I think another thing that I've learned through working in the space is that change just doesn't happen necessarily sort of naturally. Sometimes what you need are critical actors that are making active decisions so that that power is shared. And I think that in some small way, I hope that the BMJ, by working with WHO and UNU on this collection, are acting as a critical actor, and hopefully helping to shift you know, this space a little bit. So as has already been mentioned, there's more to come. We're hoping that there'll be a second wave of papers early next year. As I've already mentioned, all of the papers are open access, so we'd like you to go and read them. And if they've really made you think, then what we'd like you to do is share your thoughts and write a rapid response, so that others can see how you felt and reacted to those papers. Thanks very much.